Welcome back to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. I'm your host, Dr. Kaniksha Desai, and today we're taking a closer look at the complex relationship between growth hormone and the thyroid gland. We'll discuss how excessive growth hormone seen in conditions like acromegaly can lead to thyroid enlargement, nodules, and even cancer. We'll also explore the effects of growth hormone replacement therapy, how it influences thyroid hormone metabolism, and what this means for patients on thyroid hormone replacement. It is a privilege to have with us today Dr. Laurence Katznelson, a world-renowned authority on pituitary disorders and former president of the Pituitary Society. Dr. Katznelson has authored over 120 peer-reviewed publications and has delivered numerous lectures at both the national and international levels, including on the topic of growth hormone and its effects. He joins us today from Cedars-Sinai Medical Center, where he currently serves as the Vice Dean of Medical Education. We look forward to having a thoughtful discussion on the relationship between growth hormone and thyroid diseases. Thank you for joining us today.
Thank you for including me. I look forward to this. Thank you.
So I wanted to actually start by doing a little bit physiology for our listeners. Can you explain how growth hormone interacts with thyroid function in the body and how they're interconnected?
Sure. There are, no surprise, quite a few connections between thyroid hormone and growth hormone physiology and how they interface. We see this play out a lot, and I'm sure we'll discuss this later in this podcast, with hormone replacement strategies when it comes to hypopituitarism management, and also how it plays out in managing patients who have acromegaly, which is a situation of growth hormone excess. But even at baseline, there are known connections between circulating thyroid hormone and growth hormone. I'll give you an example of some of these that we know that growth hormone plays a role in impacting peripheral deiodination of T4 to T3. So depending on the ambient levels of growth hormone, there'll be more or less of this impact on the deiodinase, the peripheral deiodinase. We'll come back to later how that plays a role in growth hormone replacement when someone goes from zero growth hormone to normal growth hormone and what that means in terms of thyroid physiology. It's also true that growth hormone plays an important role in impacting, the growth hormone plays an important role in kind of growth of the thyroid gland. And we're going to come back to that a little later on as we discuss goiters that may be seen with acromegaly. But back to the question that Dr. Desai asked about other aspects of regulation, we also know that thyroid hormone influences growth hormone secretion. And we know this from both in vitro and in clinical studies, that thyroid hormone seems to have a permissive, if not stimulatory effect on growth hormone secretion by the pituitary gland. We know that when patients are hypothyroid, for example, that there is greater stimulation once thyroid hormone has been replaced versus patients who remain hypothyroid, and that is either secretion of the growth hormone either at baseline or with stimulation, such as when we talk about stimulation tests, we talk about using glucagon or insulin-induced hypoglycemia. And when you do these procedures in a patient who has little or normal levels of thyroid hormone, you'll see differential impacts upon growth hormone secretion, less or more, depending on the hypothyroid versus euthyroid state. So that's something also important to know. So we think about that when we are assessing growth hormone levels in a patient. We need to ensure that that patient is euthyroid, because otherwise we may have a falsely low value and think the person's growth hormone deficient when they may not be. They may just be requiring thyroid hormone normalization.
Is the opposite true with hyperthyroidism?
Yes, with hyperthyroidism, yes. So it's a good question. With hyperthyroidism, there are studies that have shown that we may have an augmented growth hormone state, that the growth hormone levels may be even higher. It doesn't appear that this will induce an acromegaly-like state with enough growth hormone surging that could cause excessive growth hormone that may lead to elevated insulin-like growth factor 1 levels, IGF-1, that's our marker for acromegaly. But you can see bumps, you can see increases. So it does appear that across the spectrum of low to high systemic thyroid hormone levels, you may see differential effects upon growth hormone secretion accordingly.
Thank you. So I wanted to start off first with the growth hormone excess, and then we can talk about deficiency. So acromegaly, I know we mentioned before, is a condition associated with growth hormone excess and is known to increase risk of all thyroid abnormalities. I wanted to start with nodules. So can you discuss the prevalence of thyroid nodules in patients with acromegaly?
Yeah, for sure. So this has been well known for a long time that patients with acromegaly. Now, remember what acromegaly is, just to take a step back. So acromegaly is a disease state characterized by excess growth hormone secretion. Growth hormone circulates in the body and stimulates IGF-1, insulin-like growth factor 1 production, in the liver. IGF-1 is kind of our marker, if you will, for a measure, almost like hemoglobin A1C for diabetes. It's a marker for how much ambient growth hormone we have. Both growth hormone and IGF-1 circulate to impact tissues for somatic growth. And there's also local impacts of growth hormone on the tissue level, usually through local production of IGF-1 to have its effect. So in acromegaly, high GH, high IGF-1. So it does appear that there's growth of a lot of tissues with acromegaly. There is soft tissue growth excess, as we see in cardiac hypertrophy, not only because of fluid excess, but there's also increase in anabolism of the cardiac muscle. So heart grows, other organs grow. Soft tissue expands the joints. There's growth of the kind of the joints may lead to arthritis. In a kid who's not had closed with epiphyseal plates, they have long bone growth. That's called gigantism. So there's a whole host of growth that may be seen with acromegaly. Now, with regards to the thyroid gland, there's several kind of important points here. It does appear that thyroid nodules, along with colonic nodules, by the way, are increased in prevalence in patients who have acromegaly. And there are a number of mechanisms why that does appear to be the case, largely through different signal transduction that causes both hyperplasia and hypertrophy of the thyroid cells along with the colonic cells and endothelium. In the thyroid gland, the data show that almost the majority of patients have thyroid nodules, well over 50%. There's a number of studies that have looked at this. It's clear that more than 50% of patients have goiter, and if you look deeper, thyroid nodules. So the thyroid nodules have been seen anywhere between 50 to 80% of patients will have a thyroid nodule. So there's been a number of questions about what to do about these, how deeply to look at these. I'm sure we'll be getting to that a little bit more in the podcast, but to say the majority of patients do have these through a number of surveys. For example, the survey that came from Liege demonstrated that thyroid nodules were present in this case, 34%, but in other studies from Istanbul, it looked like they were present in 70%. So there does appear to be a differential. Maybe that has something to do with iodine in the diet, maybe other issues that are at play here. But it does appear, bottom line, the majority of patients have thyroid nodules.
So you wrote a guidelines on acromegaly treatment and screening. Can you talk a little bit about, for patients who acromegaly, so some of our listeners take care of patients with acromegaly, what are the current screening guidelines and recommendations? Should we screen all these patients with a thyroid ultrasound? And then, what about biopsying? Should we be more aggressive in biopsying nodules in these patients?
That's a good question. And I think a lot of it has to do with what the risk of cancer is. So we just described that patients with acromegaly have a higher prevalence of thyroid nodules, and that's compared to the general population. So they do have a higher prevalence of thyroid nodules. And by the way, to add to this, the goiter and many of these nodules can reduce in size as the acromegaly is treated. So we can see a reduction in goiter size, and you can see a reduction in thyroid nodule size with treatment of goiter. So we're talking really, and your question is really key, we're really discussing what to do on the initial evaluation. So if someone comes in for acromegaly diagnosis, we've confirmed the diagnosis of acromegaly. How do we evaluate the thyroid That's the question that I believe you're asking. And then we'll follow it afterwards too, once we do therapy. But the real question is what you do up front. So the real question is, what's the risk of cancer? And because there's more nodules, is there more cancer? And if you look at this literature, it's pretty all over the place, to be honest, that there are a number of studies that have suggested that the incidence of thyroid cancer is no different really from the general population. Despite the fact there's more thyroid nodules, the incidence of thyroid cancer is no different. But there are other studies that suggest that we could see thyroid cancer in 10, 11% of patients, which would be higher than the general population. And it's in other studies, it's been found as low as 7%, and other studies up to 20% of patients who have acromegaly have thyroid cancer. So there's, and this is like it has been in literature for a lot of the malignancy type studies with acromegaly. There's a lot of changes and a lot of differences between the studies, whether that has to do with different genetic markers that may be regional. But nevertheless, that is kind of the finding we have. So it does appear there's a mixed literature on the prevalence of and incidence of thyroid cancer in these patients. So it may be increased compared to the general population. So this has, we have looked at this when we created our guidelines for the Endocrine Society, and we've also re-looked at it with more recent guidelines as part of the Pituitary Society proceedings and evaluating the approach to a patient with acromegaly, here focusing on the thyroid. And the proposals we made for the Endocrine Society and those similar for the Pituitary Society basically said, we know that we have more thyroid nodules in these patients. We know that. We also know that there's a risk of thyroid cancer, but it's a mixed literature of unclear whether there really are more or not. Likely on the level of more. So, but what the recommendations have been, at least through the Pituitary Society and through the Endocrine Society, have been not to automatically do a thyroid ultrasound, but instead to make sure you do a physical exam. And if the physical exam shows any nodularity, that person gets an ultrasound, and then manage accordingly like one would any other patient who has a thyroid nodule, meaning that we would look for size of the thyroid nodule, look for if we would biopsy it if necessary, and probably would have maybe a little higher, a little lower threshold for biopsying. And if there's any question, do more. So we would manage the thyroid nodule just like we would any other thyroid nodule, but the exam would be performed, ultrasound performed, any concern, biopsy. So it would be down that pathway. Now, to say there have been guidelines from Europe that have been different. There have been guidelines from France. There have been guidelines from England, which have suggested that we should ultrasound every patient with acromegaly. It just goes to show that it's not 100% clear the best approach to this, nor was the most cost-effective approach. But I think either way, it's really critical that an exam is done. And if the person is not comfortable with their exam, or maybe the patient with acromegaly, which can have a very thick neck from all the fluids in the neck and is unable to do a full exam, then get an ultrasound then. But in some way or some other, there needs to be some form of examination, whether by palpation or by ultrasound.
Okay, thank you. Just really some background on how this particular podcast topic came up is that we actually had a patient recently admitted with acromegaly who had thyroid nodules for years, and she saw many providers. And as you know, acromegaly is often a delayed diagnosis. So she was being followed, and it took years to diagnose her acromegaly. And by the time she was diagnosed with her acromegaly, she obviously had many of those features that are associated. Would there be any cost benefit of doing like an IGF-1 level in patients with thyroid nodules, or would you look more carefully if you have someone with a thyroid nodule? I know nodules are very, very common, and acromegaly is very, very rare. So it's like finding a needle in a haystack, right?
It's a really good question. So you're asking the question, if one sees nodules, should we be thinking acromegaly? And is it worth even screening for it? And, there are enough people who have looked at cost-effective stances on this and said it's probably not worth it, because if you ask the question, if you have a nodule, what's the risk of acromegaly? It's extremely low. Acromegaly is a rare disease baseline. But, we've also worked with physician groups to say, well, are there certain patient groups we should be screening, more aggressively? For example, patients who have sleep apnea. Almost all patients with acromegaly have sleep apnea. But you know what? Half the world has sleep apnea. Or if patients have hypertension, well, and a lot of people in the world have hypertension. Same with either early diabetes or frank diabetes type 2. So we kind of look for situations where there's a combination of some of these comorbidities, such as if you told me the patient has thyroid nodules and has sleep apnea and maybe has diabetes that's difficult to control, that combination may point us a little more in the direction of acromegaly, but honestly, there's no study that I can point to that says these are the ones we should be checking. Clearly, if they have the phenotype, meaning they have the classic physical features with the frontal bossing, the skull look, the frontal bossing, large jaw, thick nose, coarse facial features, large hands and feet, that would be reason to maybe even consider more so due to the IGF-1. So the short answer to your question is just the presence of thyroid nodules, probably not, given that it's super uncommon that those patients have acromegaly. But if there's any question in the back of your mind, like, this person's also had difficult to control diabetes, this person's had kidney stones, this person's had, which goes along with MEN1, for example, with hypercalcemia. This person has sleep apnea syndrome, and they have thyroid nodules. Maybe they've had colon polyps. That would be, I would draw an IGF-1 level on that, because now you're starting to smell a little bit like the possibility of acromegaly.
Thank you. Talking about how patients with acromegaly do have this goiter and enlarged thyroid gland, is there any specific challenges or considerations when performing either the ultrasound because of their thick neck, or if they do require thyroid surgery on these patients? Like, would you wait until their acromegaly is treated and then come back to the thyroid nodules? How would that kind of span out?
That's a more complicated question, or maybe you intended it that way. It's a complicated question, Dr. Desai, because it hits on several different parts, and I'm going to try to separate these a little bit. And please jump in if I'm not hitting exactly what you're asking. But so there's the question about operating on a patient with acromegaly for anything, just for anything. These patients tend to have thick oral pharynx and macroglossia, which can make intubation complicated. So these patients often have poor Mallampati scores. Remember, Mallampati score is the anesthesia score about how, open the posterior oral orifice is. And these patients are often thick. That's why they have a deep voice, honestly. And so intubation is tricky. So just the part of surgery, I just want to make the point, it can be tricky. And we have these patients seen by anesthesia prior to surgery. And if it's felt that their oral pharynx is too thick, is potentially going to lead to a traumatic intubation, which none of us want, then sometimes we treat those patients with somatostatin analogs to try to reduce the acromegaly, to try to reduce the degree of swelling and edema of the oral pharynx, to try to improve the perioperative management of these patients for surgery. So that's just one point to make. Another point to make is that, as I said earlier, sometimes these thyroid nodules actually reduce in size with management. So if the patient has thyroid nodules, but they're really small, and maybe they've had biopsies which don't show concerning features, or either molecular or have pathologic or ultrasound features, it's possible we could just let them go and treat the patient and see if by reducing the GH and IGF-1, some of these nodules may reduce in size. That said, if a patient has a large nodule and has either ultrasound features or biopsy features that are concerning, they should be removed. And what has to be kept in mind at that point is just what I said earlier: is the patient a good surgical risk given the Mallampati score, given the oral pharynx? Is that something we should think about? That would be the big issue. And the other thing to think about is that these patients may have a cardiomyopathy. That's the other piece of this. So the question is, are they good operative risk anyway? It's pretty common, particularly with younger patients, to have a thickened heart with a diastolic dysfunction as well as systolic dysfunction later in their path. So we want to make sure that there is no cardiac disease that would warrant us to treat medically first, because oftentimes with medical therapy, the heart does reduce in size and pump function improves. So I guess some of the answer to your question is this person a good surgical candidate for intubation and for cardiovascular management? And otherwise, unless there is a large nodule which is concerning, we could probably wait. But if they do have a big goiter that has any bit of compression on the trachea, for example, or has a nodule that is somewhat concerning, that person should probably be operated on soon. In terms of the timing of whether we should take the pituitary tumor out first, or because that's the main cause of these, or the thyroid nodule, our preference would generally be to operate on the pituitary first just to get rid of the growth hormone. It just stopped the slamming of growth hormone on the thyroid nodules for its growth, unless the person's thyroid nodule and or goiter are significantly problematic and are causing either airway problems and or just real risk of cancer.
Okay. So I think you briefly touched on this topic, but you were saying the somatostatin analogs actually, because they reduce the growth hormone and IGF-1 levels, they're going to decrease the nodules. So can you talk a little bit about how the somatostatin analogs impact thyroid function and the progression of thyroid diseases in these patients?
Yeah, so there's several ways that somatostatin analogs impact the thyroid. First off, somatostatin we know reduces TSH. So let's think about the whole axis: TRH, TSH, thyroid hormone, and the feedback loops that happen. So somatostatin reduces TSH secretion, which is one reason why we use it to treat pituitary tumors that hypersecrete thyrotropin, TSH. Octreotide or lanreotide are super useful. They're very effective at reducing TSH and managing the TSH-driven hyperthyroidism. So that's one piece of this. So TSH levels can fall. In fact, when we're using somatostatin, one can see almost essential hypothyroidism, and we need to monitor thyroid hormone in patients, measure free T4 in these patients to ensure we've not induced hypothyroidism. The other way that somatostatin can do it is somatostatin can also impact, again, the conversion of T4 to T3. So you can have from several different levels, somatostatin can lead to hypothyroidism. The other way that somatostatin can impact is somatostatin can reduce cyclic AMP, which can be an important mediator of intracellular growth, particularly through the second somatostatin receptor, SSTR2. There are 5 of them, but the second one is what's mediated by sandostatin or by lanreotide, somatostatin, both very similar somatostatin analogs, that they can lead to reduced goiter size, and they can lead to reduced thyroid nodule size, in part through the reduction in TSH, but in part through direct effects, largely through cyclic AMP and some other intracellular mediators of reducing thyroid cell size.
Do any of the other treatments do this, or just this particular somatostatin does it?
Yeah. So the other somatostatin receptor ligand called pasireotide, which is kind of a super agonist. It is one that doesn't bind SSTR2 as well, but more SSTR5. This is one that appears to be more effective at managing acromegaly because it does bind to a couple of receptors more than just one. And it is more effective in normalizing growth hormone and IGF-1. The big problem with this drug has been that it also lowers incretin secretion and insulin secretion, so hyperglycemia occurs in about 2/3 of patients. So that's one of the problems with the drug, but it's much more effective. This is another medication which can lower TSH and can also impact peripheral T4 levels. So we need to monitor the thyroid hormone levels in that medication as well. The other medications we have generally not as potential in doing this. For example, we sometimes use dopamine agonists, which are not FDA approved for the management of acromegaly in the United States, but we sometimes use them. Why? Because they're inexpensive relatively, and they're oral. So we can use cabergoline, for example, which is almost always otherwise used for treatment of prolactin disorders, hyperprolactinemia. But if you use cabergoline here, what you can do is treat the acromegaly. But cabergoline doesn't impact TSH. So in fact, that's why it's almost useless for the treatment of the TSH secreting pituitary tumors, because it doesn't do much TSH. So it doesn't really help the TSH. It doesn't really do much to the peripheral T4 levels. So the only way it would really be impactful is through its growth hormone mediation, not through direct effect of cabergoline on the thyroid axis.
Okay, thank you. I actually wanted to switch over to growth hormone deficiency for the rest, or for the next part of the podcast. Could you talk a little bit about how growth hormone deficiency impacts thyroid functions?
Yes. So growth hormone deficiency, just for the audience to understand what we're talking about, we differentiate growth hormone deficiency that occurs in children and growth hormone deficiency that occurs in adults. And growth hormone deficiency in children is largely manifested by growth disorders with short stature. In addition, early on, some metabolic problems, but with age, it's really height. That's the big issue. In adults who already have closed epiphyses, and so if adults acquire growth hormone deficiency as adults, then the real issue isn't as much height as it is the impact upon a number of buckets, including body composition, which favors more adiposity and less lean mass. Its impact on quality of life. People tend to be more fatigued, more tired, less executive cognitive functions, more depressed. It impacts bone with weakened bones, osteopenia mostly, but sometimes osteoporosis. And it seems to impact cardiovascular risk with hyperlipidemia. So it's those buckets that we look at in patients with growth hormone deficiency. It's almost always caused by, in adults who have adult-acquired growth hormone deficiency, by some trauma to the pituitary gland, whether it's surgery, radiation, brain injury. It's the most common axis that's knocked out of the pituitary gland, for that matter, with any perturbation of the sella, again, whether it's radiation, surgery, or injury. So growth hormone deficiency, amongst all of the different pituitary axes, is the most commonly knocked out if there's disorder of the pituitary gland. So back to the question at hand, when growth hormone is deficient, so that means we have low levels of growth hormone and low levels of IGF-1. What we see from the standpoint of the thyroid gland, not a lot. It depends if TSH is functioning normally or not. So if someone has panhypopituitarism, they should have TSH that should keep the thyroid gland awake. There shouldn't be thyroid atrophy. There should be normal output of thyroid hormone. So that's one important piece. It's also interesting that growth hormone deficiency may even be protective of cancer. This has been a long-standing question, that if a patient has had cancer and they have growth hormone deficiency, should we be giving them growth hormone back as replacement? Because of the question, what if we were inducing cancer? The data on this is not strong, but if anything, growth hormone deficiency is protective of cancer, and that includes thyroid cancer. So we start worrying about replacing growth hormone in patients who've previously had cancer, because then, are we going to recreate their cancer environment? So that's really the story. Growth hormone, again, does impact peripheral conversion of T4 to T3. So when growth hormone levels are low, there is more conversion of T4 to T3. If we replace, and I imagine you're going to be asking about that in a minute, growth hormone therapy, you may change that balance. But that's the other possibility.
So how does it change that balance? And what do you recommend treating first versus second?
So in the management of hypopituitarism, generally what's important to do, and this is how I approach all my patients, is we think about the different axes that are involved. We think about the adrenal axis. We think about the thyroid axis. We think about the gonadal axis. The hormones that are most critical for people are thyroid and adrenal. So we generally replace those first. If someone's growth hormone deficient, my practice has been to replace those first and see how the patient feels. If the patient feels super good, great. They're going out, they're not staying in, they're not sedentary, they have good energy, their mood is good, they feel like they have normal strength, they're not gaining adiposity, particularly around the gut, then we may not need to give growth hormone. And there's different schools of thought of this immediately. There's different schools of thought about this, admittedly, internationally. My approach to growth hormone deficiency is treat if there's reason to treat. I see clinical indications to treat, depending on or if the patient has or has not responded well to the other hormone replacements, such as thyroid, adrenal, maybe testosterone in a male, and feels fine or not. And I would replace growth hormone if they don't feel well enough after replacing the other hormones. There's another school of thought, though, for sure, that growth hormone deficiency enhances the risk of cardiovascular events. The literature is not super strong, but it is present. And there are a number of people who replace growth hormone, and anybody's growth hormone deficient, because of data out there on kind of occult growth hormone, occult cardiovascular disease in growth hormone deficient people. For me, if patients have hyperlipidemia, there's cheaper ways and easier ways to manage the high lipids. But that is just admittedly an issue that we deal with in our community of physicians. So back to this question, generally the practice is to treat the thyroid hormone first and get that replaced. Then to consider the growth hormone replacement, realizing that if we administer growth hormone, given the peripheral conversion of T4 to T3 and enhanced conversion to reverse T3, that because of the deiodinase effect, you may induce a relative hypothyroidism. And it's not unusual in patients that we are replacing growth hormone, that if a patient is on a standard levothyroxine dose, for example, that we need to increase that dose, either because A, they're starting to feel more signs or symptoms of hypothyroidism, and or we're noticing the free T4 levels falling, which could be indication of the conversion to reverse T3. So that's generally how it's done. If a patient is not on levothyroxine and their TFTs show that a free T4 is kind of normal, but maybe not in the clinician's eyes low enough to be considered hypothyroid, or they don't have signs or symptoms of hypothyroid, we could start growth hormone at that point and then determine and then follow. And if the free T4 does fall below the normal range, or the patient starts getting fatigue and cold intolerance and all of our usual hypothyroid signs or symptoms, at that point, consider starting Synthroid.
And then the opposite. So if somebody were to abruptly stop the growth hormone for whatever reason, insurance or side effects, then we have the opposite effect. You would go down on the dose, or you would at least test and then see if we needed to go down in the dose of thyroid hormone.
Yeah. There are several hormones that we have to watch for this. One of them is thyroid hormone. So if someone is on a standard appropriate dose of growth hormone, and they are on a sufficient euthyroid dose of levothyroxine, and then the decision is made for whatever reason to stop the growth hormone replacement, we generally would reduce the levothyroxine dose to the prior dose before we had started the growth hormone, or at a minimum, monitor closely, because what's likely going to happen is that they are going to be almost probably toxic on the thyroid hormone, and their free T4 is going to come back elevated. So we're going to have to reduce the dose. We generally start the reduction in the levothyroxine dose prior to their feeling it or measuring it, because we know that's going to happen. Same thing, by the way, with impact of estrogen on growth hormone. There's also interactions with glucocorticoids and growth hormone. They're kind of similar. So we would likely do a dose change of the levothyroxine if we were stopping or dramatically reducing the growth hormone dose.
So just for clarification, patients who have a history of thyroid cancer and now for whatever reason are growth hormone deficient, either through a TBI or pituitary surgery, would you avoid growth hormone replacement, or would you consider it? How would you handle that situation?
Yes. So there is a pretty large literature and set of opinions that I have included, for example, in our Endocrine Society guidelines on how do you approach a patient that has active cancer and they're growth hormone deficient and they're on growth hormone replacement, what do you do about the growth hormone dose? And the thinking here is, well, growth hormone can be neoplastic proliferating. And what if the growth hormone were to increase further the proliferation growth of a malignancy? There are protocols out there have been for treating prostate cancer, for example, of using octreotide. It wasn't terribly effective, but there have been protocols of using octreotide, for example, to lower growth hormone to see if that would help the prostate cancer. These are just normal patients, not acromegaly, just using octreotide to lower growth hormone because it may be protective. There have been protocols using the growth hormone receptor antagonist, pegvisomant, in patients who have breast cancer, with the thinking that if we can knock out all IGF-1 that's produced locally at the breast tissue, whether we will have any positive impact upon their breast cancer management. And that literature has been mixed as well. But I'm bringing this up just to show the point that there's been concern that normal ambient levels of growth hormone and IGF-1 can kind of allow for more proliferation of cancer. So back to the patient who has too much growth hormone with acromegaly, too little growth hormone in a situation of, let me start that one again. So back to a patient who's growth hormone deficient and has thyroid cancer. Given what I just discussed, and given the potential risk of growth hormone causing further proliferation of the cancer, the general practice would be to hold the growth hormone and not include any growth hormone. If the person was on growth hormone, stop the growth hormone. If they hadn't started growth hormone, don't start until the thyroid cancer is managed and has been considered to be placed in remission. And then you may ask, well, what if the cancer comes back and how long should you wait? And there's no good answers for that. And that becomes a very difficult conversation about, particularly if the growth hormone has some benefits on quality of life and muscle tone. And patients say, boy, I felt much better on it, but I'm worried about the risk of my cancer coming back. So the literature on this is not very strong. And where we see a lot of this, and I've seen this when I was with you at Stanford University, is that cadre of patients who are now college students who are growth hormone deficient because they had some form of CNS malignancy when they were much younger, and they're hypopit and they're on growth hormone replacement, but they had a malignancy where there's now a risk either of the malignancy recurring or a secondary cancer because of the chemotherapy they received. And the question is it safe to continue growth hormone as an adult? Now that they've reached peak height, is it safe to continue it? Because what if we were to rekindle either a primary or secondary malignancy with the growth hormone? And we really don't know the answer. It's probably a very low risk, and it tends to be a conversation that we have with the families, and it's a difficult conversation. It's essentially a risk-benefit analysis. How poorly or how well is the kid doing in school? If the kid's doing well enough, probably not worth the growth hormone. But if they're having a really hard time in school in so many ways, cognitively, keeping up, physically, getting around, then it may be worth considering growth hormone therapy, but there's a risk. So those can be difficult conversations. But directly to your question about thyroid cancer, we would generally stop the growth hormone.
And then, but if they've been cured for years, you could consider it after a very clear conversation about the risks and benefits.
I think so. The real question is how many years is it? Years and years, and we really don't know. There have been some people who said 5 years is a good cutoff if they are in remission at 5 years, and there's no evidence through any of the studies that there is thyroid cancer anywhere. Then that may be a time to continue. But I would urge the physicians at that time, like I would do if I was my patient, just to do kind of a risk-benefit analysis. How is the patient doing off it compared to when on it? If they say, oh, my life is just not the same. I'm feeling so much better. I was able to participate in my work much better. I was able to function as a partner at home, as a parent, as a spouse, all those things. Then, and I can't do that anymore, then it's probably worth the risk of restarting the growth hormone with the goal of keeping the IGF-1, which is our marker for efficacy, probably in the low normal, no higher than mid normal, not trying to shoot anywhere near acromegaly, trying to shoot low normal to mid normal in its values.
Well, thank you. For our listeners, do you have any key takeaways?
Yeah, I do. I think it's important for those of you who are managing hypopituitarism, for those of you who do see patients who are growth hormone deficiency, it is important, as we discussed earlier, to monitor the thyroid hormones, because it is true that we may be kind of augmenting hypothyroidism with using growth hormone. So these patients, particularly if they say, boy, you started me on growth hormone, I'm getting a little more tired. You told me I'd be feeling better, not more tired. Think about hypothyroidism and repleting that accordingly. And the other one is, if you hear or have a patient with acromegaly, you do need to examine the thyroid gland in some way. It's really important. The degree of goiter is pretty high. Thyroid nodules, I told you, are highly prevalent. And either by physical exam, if you feel comfortable with your physical exam, or by ultrasound if you don't feel comfortable with your physical exam, to ensure that we don't have nodules that need to undergo further assessments, usually with biopsy. So that would be a really important piece. Don't just let it go. Do evaluate the thyroid gland.
Well, thank you. And thank you so much for joining us today. I really appreciate the time. I know you're busy. So thank you for joining us today. And for those of you listening, stay tuned for our next episode next month. Thank you.